Right, so this is validity part 2, where I'm going to cover some of the research about the validity of the DSM, and then I'm going to do Rosenhan. I'm also going to try and do Goldstein and possibly Brown, but I'll probably run out of time. So we need to look at research that supports the validity and reliability of the DSM or contradicts it. So Rosenhan is the core one. I'll just mention that because, again, I'm going to cover it in a minute. This shows other studies as well. These are studies we can use to describe it. So we can use Blake 1973, which showed that people diagnosed in line with stereotypes. So women might be more likely to be diagnosed with emotional disorders, and men might be more diagnosed with antisocial personality disorders for things like aggressive behaviour. Yet even though they don't show any more aggressive behaviour than a woman. Yet what happens is we diagnose people along stereotypical guidelines. So some groups are over-diagnosed. Remember, we can talk about that as well with like kind of ethnic minorities and schizophrenia. Maybe that's why they get diagnosed with schizophrenia more, not because of kind of the stress involved with being an ethnic minority, like the social breeder, environmental breeder hypothesis says. Lopez claimed to try to redress cultural bias in the DSM by taking cultural beliefs into account. And he said again, this could lead to some people being diagnosed and other symptoms being dismissed as cultural norms, when they could be the signs of an illness. So again, that's against validity. We can't look at any sort of countries outside of the US, remember, for the DSM. It doesn't include cultural bound syndromes. Another study I've got here is by a Kaplan. Again, this ties into the idea that the diagnosis is male-centered. It's created by men, which means that it might kind of medicalize women's behavior. So masculine behaviors are seen as being normal, whereas feminine behaviors are seen as being unhealthy, things like that. That's Rosenhan, sorry, I'm looking in the wrong slideshow now. So if we look in this one, I've got a few more advantages and disadvantages with the DSM. So again, it improves reliability, right? They can get help. This means people can get help, and it's relatively frequently monitored and updated. There's possible ethnocentric bias. These are all things I've totally covered so far. Although again, remember, Thomas Zaz says that these are just definitions that we've come up with because they make us uncomfortable. So you hearing voices makes me uncomfortable, so I'm going to say that you've got a mental illness. Again, we can look at this around the world in cross-cultural studies. So Chandresa, or Chandrensa as I pronounce it, sorry, looked at the rates of catatonia in Sri Lanka and in British white people. And what we found was that there was more catatonia in Sri Lanka than white people in Britain. So perhaps this could have been because of different diagnostic processes within schizophrenia, or as the evaluation point says there, it's probably due to the treatment option. But we can use this to evaluate the DSM. Burnham, Mexican-born Americans have more auditory hallucinations than Americans with Mexican origins. So again, it shows that the DSM might not apply the same everywhere. So that questions its validity. Lee and Lin said that there's no difference really. So these are arguments that the DSM is valid. Again, these are all on that sheet you've got about little studies, or most of them on that sheet. And these are ways to overcome bias. So basically, we don't include symptoms which vary between cultures. We move away from the first rank symptoms and focus more on the secondary ones, which are more likely to give a reliable diagnosis. And those include kind of the negative symptoms. But really, you just need to know some studies that support the validity and some that go against it. Again, one of the key studies about this is Rosenhan. These are just the results of Rosenhan taken from the mark scheme, but it is important to kind of know all about Rosenhan in general. So we got 8 pseudopatients to go to 12 hospitals in America. They presented saying they were suffering from symptoms like voices in their head, which said things like thud, hollow, and so on. And what we found was 7 of the pseudopatients were diagnosed with schizophrenia, and 1 was diagnosed with manic depression. So straight away we could mention that for reliability, possibly. Obviously, the validity issue is the fact that none of them had schizophrenia. They all began acting perfectly normal once they were admitted into the hospital. They were like paragons of normality. And they wanted to see how long they would stay at the hospital for before they were released, before doctors figured out that they didn't have schizophrenia. Remember, key point, none of them were identified as not being schizophrenic. Even when they were released, they had schizophrenia in remission. The doctors still thought that they had schizophrenia, but they just weren't showing any symptoms at the moment. So they never figured out that they weren't schizophrenic. The average stay was 19 days, ranging from 7 to 52. And then we've got all that sort of data about further things about the study. So staff ignored patients. They didn't have much privacy. So like the toilet doors didn't have doors, sorry. The toilets didn't have doors on them, so they had to urinate and defecate in public. They ignored them. They spent all their time in their office and spent very little time moving around with the patients. 35 actual patients, remember, identified the pseudo patients as not being mentally ill. The patients did this better than the doctors. Normal behaviour was seen as being symptoms of the illness. So waiting outside the canteen was referred to as being orally acquisitive. They were referred to as having writing behaviour because they were making notes. And they also interpreted kind of their background factors as causes of schizophrenia. So if they said they'd been smacked as a child by their parents, this was interpreted as being kind of an abuse that brought about schizophrenia. So Rosenhan concluded staff were unable to distinguish between sane and insane. In the second study, remember, this caused a lot of uproar. So what they did was he said, I'm going to send more pseudo patients to your hospitals. And what I want you to do is tell me who who you think is faking, who is a pseudo patient. But remember, he didn't really send any of them. So he said he was going to, but he didn't. And we've got the second set of findings on a different PowerPoint, which I'm going to have to open up because this obviously doesn't cover them. It was a percentage which I cannot remember. I fully apologise. 193 patients were assessed. 41 were rated as pseudo patients by a member of staff, 23 by a psychiatrist, and 19 by both a member of staff and the psychiatrist. So 193 patients, and as you can see, large numbers were said not to be mentally ill. So we can't tell if people are insane in the first study, and other way around, we can't tell if they're sane in the first study, we can't tell if they're insane in the second. So we need obviously be able to evaluate Rosenhan. I do have some evaluation points of this. Basic things, we should be able to do this. So the hospitals were of varying quality. Some were rich, some were poor, some were private, some were public. So we can talk about the generalizability of that, but it is just 12 hospitals. We can talk about the reliability. They were sent obviously to 12 different hospitals, but they were by themselves in each of the hospitals, so we can talk about inter-rater reliability. It's questioned about kind of how well they were able to record their experiences, whether they may have missed things out, obviously. But it's a participant observation, so they've got lots of in-depth detail and data. And being a participant in the actual observation in the group themselves meant that it improves the validity. Objectivity of the pseudo patients may have been affected because they weren't allowed to leave the hospital. Yeah, you can imagine that you may have viewed doctors and nurses very negatively if you wanted to leave, but you couldn't. Remember, we can't really blame the doctors, because the schizophrenic people turned up. Schizophrenic pseudo patients turned up and pretended to have the symptoms of schizophrenia. It's in a real hospital, so it's ecologically valid. But again, all of them were in America, and so on and so forth. Application of this being that we can change the way that we diagnose mental illness, or we can look at the way we diagnose mental illness. So that is Rosenhan. And what I'm going to do very quickly is Brown now, because Brown's a much shorter study than Goldstein, and then we'll move on to some other things as well. So Brown was a study in 1986, remember? This is your study for depression. They may ask in the exam for a study about depression, and they won't name it. Your study is Brown. It's also possible to use this as evaluation when it comes to the reliability of the DSM. So remember, we look at kind of life events as a cause of depression. If you've had lots of traumatic events, then you're more likely to be depressed. But you do have protecting factors. Remember, some people get depression when like a family member dies, and other ones don't. It's thought that two kind of intervening factors in this are self-esteem and social support. So what Brown set out to do was study this. So there are three hypotheses. Crisis support protects against depression, even if you have low self-esteem. Lack of support and low self-esteem are vulnerability factors, so you're more likely to get depression if you have low self-esteem and no support. And support from a close relationship reduces that depression, having that support. So we got women aged between 18 and 58 who had a child living at home. Some were married to men with manual occupations, so they didn't have a lot of money. They were generally like average people, and some were single mothers, resulting in 395 taking part in the study. We did two phases. This is a prospective study, remember, so we're looking forward rather than back. We measured their self-esteem, personalities, and psychiatric history. And then 12 months later, we looked at any life events that had happened, their social support, and if they developed a mental illness. So again, self-esteem, personalities, and history. And then a year later, we looked to see what life events they'd had. These were done via interview with experienced interviewers, and we integrated the reliability of them using on 11 of the women. So in the results, we've got 303 women. We got rid of 42 of them didn't want to take part, so there's withdrawal, good ethical point. 50 were excluded because they had depression in stage 1. We want to see what life events caused depression, not how people with depression dealt with life events. So about half of these 303 had experienced a severe event or major difficulty within the last year. 32 had depression onset. So this means that, I'll move on. 91% of that 32 had experienced a severe life event in the last 6 months, compared to only 23% without depression. So life event seems to be a massive influence on whether you get depression or not. Self-esteem, 33% of them had low self-esteem, whereas only 4% in those without depression. So again, having low self-esteem is a big factor. And when we looked at social support, we can see that it's massively helpful. 92% of women thought it was helpful. So we are able to conclude or look at the results and say that self-esteem and social support are protecting factors from depression, and life events are an influence. I'm going to move on in a second. I'm trying to think I've got enough time for evaluation. I'm going to give it a shot. So we can evaluate Brown. Just fast forward through the slides, sorry. We can evaluate Brown on many different factors. So first off, remember, this looks at women's depression, so it can't explain men's depression. There's the generalizability. Also, it's a largish sample, so that should be okay, but all of the women were from similar kind of backgrounds or had similar lives. It looks at a nurture rather than nature point of view. Reliability, we've got that iterator reliability, the interviews, we did it in the same way. But as they're interviews, there's a chance of kind of interpretation possibly, but they were experts, so probably not. Validity, we can look at obviously things like social desirability. They're not likely to say that their husband has been of no help whatsoever. But remember, it's hard to pull apart these things because if men are involved in those traumatic life events, they might not actually be seen as social support. Again, there's more to it than just social factors though. Some participants who suffered traumatic life events, did not develop depression. So lots of factors are involved, it's not just life events. That should probably be enough to get you started. There are more points we can obviously make. If you look at the PowerPoint, there'll be some there. I'm just doing this fairly quickly. Right, thanks. I'll do the next video on Goldstein, and then we'll start talking about schizophrenia.